Everyone, and welcome back to my channel. From today, I'm going to start with revising for my final MPPC exam, as it's just going to be in 15 days. So basically, I'm going to start the videos from Obs and Gynae. So today, I'm taking Obs and Gynae, as I have a booklet of IMPs, which I took out from the prelim question banks and the PYQs, and also some important topics that are needed to be covered. So basically, I'm going to start with Obs. So today, I'm going to go with all the Obs topics from the important list. So let's begin with it. So the questions that are asked are: define oligohydramnios and polyhydramnios and enumerate 4 causes of oligohydramnios. The second question is oligohydramnios, its causes and fetal effects. Then the question is cause and complications of polyhydramnios, and the last question is amniotic fluid. So I'm going to cover this in this video. And also from placenta and fetal membranes, the question asked is functions of placenta. So we'll cover this also. In this chapter, we have functions of placenta, in which we have 6 functions of placenta. The first one is the respiratory function. The second one is the nutritive function. The third one is the excretory function. The fourth one is the endocrine function. The fifth one is the barrier function. And the sixth one is the immunological function. So these 6 functions are important for the placenta. So the first one, that is the respiratory function. It is what? It acts as a lung, as a fetal lung. So it is helping to for the diffusion of the oxygen from maternal blood to the fetal blood. It also takes carbon dioxide, means it diffuses from fetal blood to the maternal circulation, which is then exchanged from the maternal lungs outside. Then we come to the nutritive function. The substances that are transported are glucose, amino acids, fatty acids, vitamins, electrolytes, and water. So these are the basic essential substances that are nutritive. Then comes the mechanism of transport by which these substances are transported. So that is simple diffusion, facilitated diffusion, active transport, and pinocytosis. Then we come to the excretory function. The excretory function means placenta acts as fetal kidney here. Respiratory function, we saw that the placenta is acting as the fetal lung. So in excretory, there will be fetal kidney. So what happens here? The waste products from the fetal metabolism that will pass into the maternal blood, like urea, uric acid, creatinine, bilirubin, and carbon dioxide. Then these substances, waste products, are then eliminated via the maternal kidneys and the lungs. The endocrine functions are, it helps in the transfer of the hormones, that is HCG, progesterone, estrogen, HPL, relaxin, placental growth hormone. So these are the hormones that are the endocrine function of the placenta. Then we come to the barrier function, which prevents many harmful substances from reaching the fetus. That is, placenta is acting as a barrier. Immunological function, that is, maternal immunoglobulins are transferred to the fetus. The second question is define oligohydramnios and polyhydramnios and write 4 causes of oligohydramnios. So what is oligohydramnios? It is clinical condition in which during pregnancy there is amniotic fluid decreased. So here the AFI is less than or equal to 5 cm and the single deep pocket is less than or equal to 2 cm. What about polyhydramnios? It is a clinical condition during pregnancy in which there is excessive amniotic fluid. So there is excessive amniotic fluid in polyhydramnios and the AFI is more than or equal to 25 and single deep pocket is more than or equal to 8 cm. Now we come to the causes of the oligohydramnios. So basically this is not the correct way to write the causes. We need to write is that fetal causes, then placental, maternal or membranous, maternal, and any drugs. So these are the classification of causes of oligohydramnios. So basically in fetal, what causes can be? So in fetus there can be urinary tract obstruction, because of which there is reduced production of urine outside. Then there is difficulty in swallowing. Then there is polycystic kidney disease, or there is any renal agenesis, or there is IUGR and chromosomal abnormalities. These are genetic causes. Okay. Then we can also have placental causes, in which we have the placental insufficiency and placenta abruption. There can be PROM, which is membranous cause. Then there can be maternal causes like postpartum pregnancy, or there can be pregnancy-induced hypertension, preeclampsia, and dehydration. Then there can be drugs that cause this oligohydramnios, that is ACE inhibitors and prostaglandin synthesis inhibitors. So these are the causes of the oligohydramnios. Now we come to the fetal effects of oligohydramnios. Fetal compression deformity, that is causing limb contractures, clubfoot, flattened faces. Potter sequence. So first is fetal compression. Second is Potter sequence. Here it is due to renal agenesis. Here we can see pulmonary hypoplasia. There can be pulmonary hypoplasia, flattened nose, low set ears, and limb deformities. So there is pulmonary hypoplasia, flattened nose, low set ears, and limb deformities. Then comes the pulmonary hypoplasia. Then comes umbilical cord compression, in which there will be fetal distress and variable deceleration on CTG. These are the clinical findings in fetus. Then comes the IUGR, which is the most important one. And then comes the increased perinatal morbidity and mortality. Now, what are the causes and complications of polyhydramnios? The causes are fetal, maternal, and placental. Fetal causes are esophageal atresia, duodenal atresia, anencephaly, cleft palate, hydrops fetalis, multiple congenital anomaly, and maternal causes are diabetes mellitus, RH incompatibility. Placental causes are twin-to-twin transfusion syndrome and placental tumors like chorioangioma. The complications of polyhydramnios are maternal में breathlessness, preterm labor, prom, abruptio placenta, and PPH. Fetal complications may be malpresentation of the fetus, umbilical cord prolapse, preterm birth, fetal distress, and increased perinatal mortality. Now the topic is amniotic fluid. What is amniotic fluid? It is a clear, slightly yellow fluid present in the amniotic sac surrounding fetus during pregnancy. And its sources are, in first trimester, it is formed due to maternal plasma and the diffusion across the fetal membranes and fetal skin. And in second and third trimester, it is completely dependent on the fetal urine, fetal lung secretions, and there is some contribution of placenta and fetal membranes. Then how it is removed? So it is removed by fetal swallowing, absorption through fetal membranes, and transfer to fetal circulation via placenta. Now, what are the functions of amniotic fluid? It protects the fetus and it provides a cushion. So it protects from trauma and provides a fetus cushion. Then the temperature regulation, it maintains the intrauterine temperature, allows fetal movement, and lung development also helps. It's helped by the amniotic fluid. It also prevents adhesions of fetus with membranes, and umbilical cord protection. What are the normal values according to gestation age? At 12 weeks, it's 50 ml. At 20, it's 400 ml. It's 28 week, 800 ml. 34 to 36 weeks, it is 1000 ml or 1 liter. At term, it's 600 to 800. And at 43 weeks, it is 200 ml. So what is the composition of this? The composition is water, electrolytes, proteins, glucose, lipids, urea, and creatinine, and fetal cells. Fetal cells can be used for amniocentesis. Now the clinical findings can be, if there is a decrease in the amniotic fluid level, then it is oligohydramnios. If it is excess, then it is polyhydramnios. And if it is meconium stained, then it is meconium stained liquor. Now what is amniotic fluid circulation? So first thing is, fetal kidneys produce urine, which enters the amniotic cavity. Fetal lungs secrete lung fluid, which enters the cavity. Now third, that is fluid surrounds the fetus. Then comes is what? Fetal swallows the amniotic fluid, and fluid is absorbed from the GI tract, which goes into the fetal circulation, which returns via placenta again, and cycle is continued. So that's all about this chapter. Thank you.